Thank you very much for coming to this session today, everyone, titled Learning from the Birmingham and Solihull Integrated Care System, Building Blocks to Addressing Ethnic Health Inequalities Through Integrated Care. I'm really pleased to be joined by Dr. Modupe, who is a consultant in public health, and also Dr. Onyinye, who is the chair of the BLACHIR ICS Taskforce. So I'll pass over to them. Thank you.
Thank you, Eloise. And I think we'll start off. I think Modupe, you're starting.
Thank you, Eloise, and thank you, Onyinye, and thanks to colleagues on the call. We'll start the session by presenting some of the work that has been going on since the BLACHIR report was produced, and the ICS led by Onyinye got involved in leading on the implementation of the recommendations from the work that was carried out alongside Lewisham Council, the London Borough Lewisham. Onyinye will walk through some slides and just talk us through some of the work that the ICS has done. And once she's done, I will spend some time just getting her to explain to us what the learning was, what approach the ICS took, and how they are continuing to shift the dial on behalf of the Black community within Birmingham, and also take that learning to wider ethnic groups as part of trying to help us do more to celebrate and connect with communities, and also to share emerging practice and learning, which are two key themes from this conference. So I will start to share the slides, Onyinye, when you're ready.
Yes. Thank you so much, Modupe. Hi. Can you hear me well? Can you hear me loud and clear?
We can, yes.
Oh, fantastic. Now I was about to panic. Hi, everyone, and welcome. Thanks for joining us. So my name is Dr. Okonkwo, and I am a GP, but most importantly, I chair the task force, like Modupe said, which is a BLACHIR ICS task force. So we are from Birmingham and Solihull ICS. And BLACHIR, which is Birmingham Lewisham African Caribbean Health Inequalities Review, was a program, or is a program, because it's something that we're running at the moment. It's a program that was started, I think it was 2020, by our DPH, Dr. Justin Varney, and the DPH for Lewisham. You know, when we had the George Floyd incidents, they noticed that a lot of the African and Caribbean communities were dying, and that was at the height of the COVID era, and we had the George Floyd, and they couldn't explain what was going on and why we had such death rates and all, and they decided to do a bigger deep dive into what was going on and try to see if there's anything that could be done differently. And so last year they published this review that looked at that had collected evidence, both scientific, lived experience, and that is what we have as the BLACHIR review. And within that BLACHIR review, they made some recommendations, which we are looking at as opportunities for action to try and look at give us a better insight into the health of the African and the Caribbean communities within Birmingham and Lewisham. Because Birmingham is more like a whole city, and Lewisham is like a borough. We've all kind of taken it away and interpreted it differently. So we launched it here in Birmingham in June, and in September of last year, we created this ICS task force. So our ICS task force is made up of all the system partners within the ICS. So just go back a little bit. So within the review, the BLACHIR review, it has some specific themes that they want us to look at. So things like racism and discrimination, the wider determinants of health, look at early years, pregnancy and parenthood, children and young people, lifestyle, aging well. And within each of these themes, they actually made so many recommendations within them that we are supposed to interpret. And it wasn't just the health system, it was now actually across the whole ICS. So for those that don't know what an ICS is, an ICS is like an amalgamation of the NHS, community partners, public health, city councils, everybody around the table trying to look at the health economy and make sure that it works. So we then, when we formed that task force in September, took it away and started looking at how do we interpret this and how do we work on these opportunities for action to be able to deliver them. Next slide, please. So let's talk about, first of all, what does this look like? Because why was this so important that it's been done? I hope some of you would have had the chance to look at some of the evidence that is coming out from the Race Observatory. You can see that, yes, the reason why they had to do this big review, because when you're talking about Black women dying, having the likelihood 4 times of dying in pregnancy, or when you start talking about us having, like during the COVID, twice mortality risk compared to people from white British background, or when you're talking about us having up to 3 times the possibility to develop prostate cancer, obviously you have to take a step back and look at why is this happening. So it's figures like this that were published from the NRO that I'm sure prompted them to decide to have a deeper dive to see exactly what can be done and what we can do about it. Next slide, please. So coming to our local system, what's at play within Birmingham and Solihull? So Birmingham, for instance, has the highest infant mortality rate. Okay, and then when you look at a report that was published in 2020 by MRAIS, that was part of where they talked about the maternal mortality. Yeah, we have, while white mothers, you can see, is 9.54. Black mothers is 37.19 per 100,000. That's quite a lot. We have the risk of developing cardiovascular dementia 10 years earlier than other ethnic groups. We have higher risk of asthma and strokes. We're more likely to be seeking emergency help. And those of us, the proportion that die at home is 68%. Compared to when you're white. And obviously look at the figures for prostate cancer, but also look at the mental health. 1 year before suicide, a Black Caribbean man would have contacted the mental health services at least 3 times. So those are figures that are quite stark and you know, not very comfortable to look at. So that's why we're really grateful that this was done, so that we can start looking at those opportunities for action and see what we can do about it to make sure that these figures are not repeating itself. Next slide, please. So this is what our ethnicity in terms of the African and Caribbean, because within Birmingham and Solihull, we have 6 localities. And within those localities, it was really important for us to understand who was where. And you can see the West localities where we have the highest number of African and Caribbean population, which is about 19%, and the least place is in Solihull, which is 2.33%. But even at that, you're talking about almost 6,000 patients. So we have to really look at what we can do to make their lives better. And I'll show you the significance of why we had to break our ethnicity down so we could understand and bespoke the services we were doing. Next slide, please. So obviously, we launched our ICS health inequality strategy because our system, Birmingham and Solihull, is really committed to trying to tackle health inequalities. Because if you look at the evidence, we're actually the area or the ICS that has that is at the lowest bottom when you talk about core 20 plus 5. We have at least 40% of our population that are in that core 20 when you're in Birmingham, and I think it's about 12 or 13% in Solihull. So we are the most deprived ICS nationally. So one of the first things that we did when we had an ICS was to create a health inequalities strategy so that we can start addressing these things. So you can see our 6 priorities and the building blocks that we've decided to use to be able to work on those 6 priorities. And we're trying to change the way we are working. And that was the thing that we had to do with the BLACHIR work. We had to align it to what the system is doing, because the way we report, we have to report to the system. So the better way is to align it to the way, you know, the strategic work of the system so that it works, it follows the ICS vision, so that we know that we're all singing from the same hymn sheet. It's always better if you have a joint vision, because that really matters to what can be done at any point in time. Next slide, please. So our journey so far, the first thing we did was to look at the recommendations and map it, because you need to have a memory. You need to look at what have you done or what is being done. Because what I'm finding day to day is that we're doing so much within our systems, but sometimes we don't have that headspace or the time to pause and actually look at what are we doing. If you know what you're doing, then you can decide what you need to do better. So we brought everybody around the table. So the whole system is actually committed as an ICS to this work. So we have all the providers, we have all the community care, we have primary care, we have 3 community engagement partners actually working with us and co-producing every single thing that we are doing and advising us and giving us that insight of the so what. How, when you're saying you're doing this, how is it making a difference within my community? So amongst that, we have an African representative that works with the African communities and has all the contacts within the African groups. We have one that looks after the Caribbean communities. And of course, we mustn't forget children and young people, because those are some of the people that sometimes we forget that they have a voice. So we have one that actually looks after the children and young people and actually has a youth council, so that whatever we are done, we are trying to make sure that no one is forgotten. But around the table as well, we have organizations like Health Watch, who are making sure that they are keeping us accountable. We have, although it was started off with Birmingham, we now have Solihull around the table as well. The local council in Solihull is around the table as well, so that we make sure that whatever we are doing, because one of our strategies within the ICS is that we want to work as a unit. We want the ICS to join up so that whatever we're doing, not just align it to what we're doing, but also we want to make sure that we work as a unit, as an ICS. So that was the first thing we had to do, to create that task force with everybody around the table. And because it's so aligned to our health inequality strategy, we've had a health inequalities team facilitating, supporting, and being the back office. I'm sure I have noticed Jen on the call today, who is so busy behind, being my powerhouse and arranging all the things for me. And we, at the moment, we meet every fortnight, because we think this is so much important work that we have to really commit to it. Because if you want to get the community to trust you, they have to see that you're committed to it. It's not something that you do today and then in 2 months' time you're doing it. No. We meet every 2 weeks and we hold ourselves as the providers accountable, but also we let the community engagement partners hold us accountable. So like I said, the first thing we did was to find out what is being done around the system already based on those 36 opportunities for action. And then we did that the first 6 months, but on the back of it, we were doing other things. And then the second thing we did was also to look at, for the next 1 year, what are the SMART goals? We've asked each provider to come up with 3 SMART goals, which was actually marked by our community engagement partners to make sure that for them, it's answering that question of, so what? How would whatever SMART, so when you talk about SMART goals, you're talking about something that is specific, you're talking about something that is measurable, you're talking about something that is achievable, something that is relevant, something that is timely within the next month. How is it going to be relevant to the communities? And when they all came up with their different goals, it was sent over to the community engagement partners, who actually co-produced it to make sure that it made a difference, so that it's an impactful goal. So it's not just about we're going to do this, but what does it feel like to the communities? And like I said, we had to map it against our ICS strategy of belonging to BSol and also all the other strategies that we had. But the wonderful thing was, last year in November or early December, we had what we call the BRIC conference, where our system, our chief executive, David Melbourne, actually stood up and committed the system to delivering on this work. And I think that also gave us that legitimacy to be able to do this work and be able to develop it and be able to run with it and commit to it. So these are just some examples of some of the SMART outcomes that we're currently working on. Like you can see, primary care. One of the things that our community engagement partners said to us is that they want us to create a page on our website that they can go to and look at the all the processes and look at all the resources that they need to be able to engage with their communities. And you can see that's in green. We're actively doing that, thanks to our health inequalities team that is also supporting primary care to do that. And another thing we wanted to do in primary care was to actually get the ethnicity breakdown, because we have health inequalities leads within each primary care network, so a group of practices working together. They need that data to be able to see who is where and what illnesses they need to be focusing on. Like I said, we really want to focus on health inequalities within our system. So at least with this tool, we have the tools to be able to make a difference. Then the EDI team, they are currently developing our EDI strategy for the system, but also they are doing talent mapping, because we also committed ourselves to not only being an anti-racist city, we said we want to diversify our leadership as much as possible. And who better to lead it than the EDI team within our ICB? So that's one of the things that they are working on. Next slide, please. Then our Royal Orthopedic started off with the Black interns. It's something that they are doing, and we're now beginning to scale that up. And University Hospital Birmingham, which is one of the biggest hospitals within our, in fact, it's the biggest hospital within our system. They want to focus on DNAs within the African and Caribbean communities to see how we can reduce that by 10%. They've started training their staff on sickle cell. They have a proper training program that they are rolling out to all their clinicians, because we know that when people have sickle cell crisis, they want to make sure that people understand them and offer them care that is culturally humble. And it's not just a question of your seeking, your drug seeking, which is something that they've said to us sometimes they find, and that their care, whoever is looking after them, understands the nuances when it comes to looking after African and Caribbean patients. So they've rolled out a bespoke training, but on top of it, they've also started piloting a religious and cultural humility training for their staff, and we're all actually looking forward to that. And based on their CQC inspection recently, they've now gone ahead and decided to do yet another program, their maternity and neonatal improvement program. If you remember, I said to you, infant mortality is a main focus, is one of our health inequality strategy for the system, because we have the highest rate. So UHB has decided that they also want to focus on it, but not just focus on it in terms of reducing the numbers, but also look at it specifically within the culture and inclusion work stream. Next slide, please. But within all that, we also have now started looking at developing other programs as well, because what we started finding was the communities want to engage with the system wants to engage with the communities, but it's that in between that we seem to be lacking. And we did a community project. The very first one we did was in April of this year, where we actually took the health, because that was the thing they kept saying to us, they want to engage. We decided to actually take the NHS out into the community, so that the community can see and also hear from us, and we can hear from them. So we did the very first one in April, and I think we have a slide here that will show you the result. And what they said categorically is that they want us to bring the health out into the community. So based on that, we started now developing programs. And also our community engagement partners said to us, what they want is to be able to have access to, if you're saying where our cardiovascular rate is very high, most important thing behind it is hypertension. How can we create a program that will get people to check their blood pressure wherever in the community? Can we go back one slide? So we are now developing this particular, what we call the CVD hypertension awareness program in the communities. So we are going beyond the one that is being done nationally, where people can go into the pharmacy. We are actually now, number one, training communities to check blood pressure within the community. So people can go into a community venue and get their blood pressure checked. They can now, we've developed QR codes. We're going to launch this in this October, but we've got everything almost ready. And Jennifer is leading on it, and she's done amazing work with it. People can now go into a community venue, have a QR code that they can point their phone at, and the QR code will take them to our Healthy Heart website that has been created by the ICS, and they can hear languages in their own languages. So we're interpreting the message in common languages spoken around Birmingham and Solihull, and they can hear culturally sensitive lifestyle advice and guidance, so that they can know, because our people are visual. We want to hear rather than read. And that's why we decided to create these videos, and create videos that they can understand in their own language, and talk to them about blood pressure, what it's all about, why they need to check it, where they can go and check it. And then they can go to these community venues. The ambassador will check it, give them advice, direct them to a pharmacy who can then send them into the GP system. And this bypasses all the access to GPs, and make sure that patients are not waiting and they decide, oh, I'm not checking it because I can't get an appointment. So this is quite innovative for us. And we started this in West Birmingham. If you remember, I told you that we have the highest number in West locality, and they're so enthusiastic to work with us. And we're really trying to make sure that we bespoke programs. But now we're beginning to think about scaling it up. So this one we're launching this October. Next slide, please. The other program that we're working on is about the prostate cancer. This one is still in development. So the first thing that's been done is a local search of the people that are eligible. We're working very much with Prostate Cancer UK. So every engagement that we're doing in the community, they are coming along with us. And actually, the group that are looking after the children and young people have created a men's council, where they have a group of men that come together and they talk to each other, and they look at what are the health needs and how we can tackle them. So this one is one that we are now developing. We've actually had one of the community engagement events on a Saturday that one of the PCNs ran, where they had a Saturday clinic and the men could go. And also, but this is being led by our community engagement partners, telling them what exactly that men's council want to see and what can be done for them. Next slide, please. So, and also our city council, who is leading on the project, they've been developing programs around, because what we want to do is everybody within the system, as much as possible, to have some cultural intelligence and humility training, because it is so important for us to understand each other culturally. If we do, then we can relate with each other at that level. So we've divided it into two programs. One is the Cultural Intelligence Program, which is being led by our Director of Public Health, Dr. Justin Varney, where they are looking at all the people that make policies, all the people that have those strategic decisions to make, having this training, the cultural intelligence training. And it's been co-produced with our community engagement partners, asking them, what do you think your NHS leaders need to know about you? And at the moment, it's been piloted and done around the system, where they've developed the first bit of it, and we've now Justin has rolled it out for people to input and say what it feels like to them. The cultural safety and humility training is also being developed. That is being led also by the City Council, and they are working on it. So the other program that we're doing as well is the infant mortality and the LMNS team. So we have a dedicated SRO, a senior responsible officer for infant mortality, Dr. Diti Yotish, who you can see in the picture, who is quite passionate about making sure that the system does something about this. But for us, from our side, because of the figures that we are having, African and Caribbeans have the second highest rate of infant mortality, but we have the highest rate of maternal death. So what we are doing, we're facilitating these two teams going into the GP practices. So within Birmingham and Solihull, we've created a single point of access for all women that are pregnant, so that they can bypass the access problems within GPs, register themselves on this new system, and they are picked up straight away by a maternity link worker. And that person supports them all through their journey while they're pregnant, because sometimes some of these ladies they've come from abroad, or they don't understand the system. Sometimes they don't speak English, but there is somebody there supporting them, because one of the things that causes infant mortality is that not taking their vitamin D or taking their folic acid by 12 weeks. But this way, we can get them registering early, and then on top of it, we can get somebody alongside them to make sure that they are taking the right medication at the right time, and also be able to advocate for them and walk them through. So from our point of view, we are facilitating these discussions with localities and getting all the GP practices to make sure that they are registered. And like I said, we've now taken the health out into the community. So you see us running lots and lots of community engagement events. Like I said to you, this is the slide where, because everything we're doing, we're evaluating it because we want to be able to show what the community felt about the event, what are we learning from the event, so that we can use that not only to inform the next event, but also to share the learning. So these are some of the events that we've done so far. We've done one at the Central Mosque. You can see Mandi Nagra, who is one of our executives for policy. You can see another one we ran in another mosque. The next one we ran in Green Lane Mosque. You can see me in my nice scarf. And then this is the one we did. The next one, please. The Windrush event. We went into the West Indian chaplaincy, which was the first chaplaincy that was created in Birmingham and Solihull when during the Windrush era, when they first came. So we went and did a community engagement program for them. Next slide. Then we've done some with the African community. This is myself and a community and a consultant psychiatrist discussing with a group of African women about mental health and well-being within the family. And the next slide, please. I think this is the last one. We've done two actually, community engagement event on diabetes. This was the one that we did for the national team. So the national diabetic team came down to Birmingham and ran this community engagement event. And it wasn't just open to African and Caribbean communities. That's what we are seeing, because like I said, it's not just, we've gone beyond just the African and Caribbean communities. We're trying to get the help out into other communities, share the learning, let people have access to health within the community, because part of the things they do, they check their blood pressure. The people that are diabetic get to hear about the food, they get to have their feet checked, and all that is all about the health of the communities, making sure that the community is engaged and they feel like somebody actually cares within the NHS. Next slide, please. So what are our next steps? So now we're looking at delivering the smart outcomes that we've co-produced. We want to start facilitating more community engagement event, because our vision for it really, now that the PCNs, our primary care networks, are beginning to do so, because some of the ones that you've seen were done by the primary care networks, maybe they can take on the responsibility to make it business as usual, but also to share learning across the communities with our communities, our localities, so that people, because now if you look at Birmingham and Solihull, you see quite a lot of these community engagement events going on. I think last week there was one in Solihull. So we are all learning from each other to make sure that in time to come, because our 10-year strategy says we want to improve life expectancy, 10-year life expectancy for every single person, and not just improve that life expectancy. We want them to be healthy in that as they live longer. And that is what we're trying to do, not just for our communities. Now we're trying to share the learning across the system. And I think that is my last slide, Modupe.
Thank you very much, Onyinye. I'm just going to come back to the screen. Thank you. I'll just begin in the chat to see if we have any questions yet. Whilst we wait, Eloise, I assume people are able to drop questions in the chat. I have a couple of questions for you. Brilliant, thank you. I mean, it's clear from what you've presented, Oyin, that a lot has been going on. And I know you've been the chair of the BLACHIR Taskforce within the BSol, so Birmingham Solihull Integrated Care System, for about a year now. And it's clearly been a journey, an upward journey of progress and learning and shaping and making a difference. And the moral obligation, as you say, to make a difference and change or shift the dial for the Black African and Black Caribbean communities, but also more importantly, take that learning across a wider range of community groups, because we know that Birmingham is now termed as a super diverse city because of the ethnic minority population there. And I guess it's really, as you've said, focusing on what we know works. So, you know, Sir Michael Mammoth has said very clearly that we take a proportionate universalism approach, where we deliver universal services in those places where we know the need is greatest. And that's what you've identified. And also the core 20+5 agenda, which is both for adults and for children and young people, where we identify those key areas of health need, the 5 areas, and you're tackling those and looking at them to address what we know is really preventable or avoidable disease and death in the 21st century. So trying to shift society by working with communities, it's all really amazing. And what we want to understand is how, as you said, and you described so eloquently, the integrated care system in Birmingham has been able to do that. What would you say are the building blocks that you've identified within this sort of journey of the last 12 months?
Right, thank you. I think the fundamental thing that we found, it's to build on your existing work, because I promise you, as a system, everyone is doing something. But the only thing is, and that's why this ICS is such an opportunity for us to learn and be able to join up, because we are already doing a lot, but when you don't bring it together, we don't know what is going on in the system. And that was why we spent the first 6 months looking at what is already going on in our system. How are we already responding to some of the opportunities that they were giving us? But going beyond not just the system with the memory, because when you know what you're doing, then you can build on it. Then you can decide what is working and what needs to be done better. But most importantly, it's also building the trust with those communities, because the thing that the communities tell you over and over again is what is going to be different this time. Because what we found when we first started was a lot of our community, they've been underserved for so long, so they don't trust the NHS as much. So going in and being that consistent voice and showing that dedication, and the fact that the system committed itself and said, we want to commit to this, we want to deliver this, we are committed to actually making a difference, was really important. And understanding the different groups that play, because when we say African, what does that mean? Africa has how many countries? I'm Nigerian. Even within Nigeria, we have 200 and something languages and different tribes. Trying to understand them at that level. Our city council has even created community profiles, trying to understand these communities and trying to understand their needs, so that when you are designing healthcare, you have them around the table with their profiles and that understanding, making sure that you're actually doing what they need rather than what you think that they need. And also knowing those local assets. I think I have another slide deck, and if you want to share that
Am I
looks
sharing
at
now?
Yes, please, if you can.
Okay. Am I sharing it now? Can you see?
Yes, please. No, I can't see
my
not yet.
Okay,
no,
sorry.
not yet.
So just going back to your point, so am I sharing my screen now?
Yeah, you're sharing your screen, just not the slide.
So can you see the slide now?
Yeah, I can see it. So I think the next one after this talks about, the commitment from our system, isn't it? Yeah, trying to make sure that when we say we're going to do things, we actually do it. So we had to make sure that we had our reporting processes in place so that they would trust us that we're going to deliver. And then we looked at our local assets. What do we have in already that can hold us accountable? Yeah, making sure that we define what the priorities are. What do we want to see done? And then aligning it to the system. So for us, that is the building block to making sure that this work is done and is sustainable and the system commits to it.
Thank you very much, Onyinye. And surely building trust takes time. How have you been able to manage that, considering that, for example, one of the stats you showed us showed that death at home within the Black African and Black community and Black Caribbean community is much higher than others. We assume that's perhaps a proxy indicator of people not trusting the system enough to come in to seek early help. So, it does take time, doesn't it? I'm sure there are challenges that you're still facing now in trying to navigate the trust building and trying to get everybody on side. Would you like to share some of that with us?
So we knew we had to involve as many of us as possible. And that is what this is. That's why we had to align it to our health inequality strategy. Most importantly, number one, having everybody around the system. So no matter who you are, so we have our biggest hospital, University Hospital Birmingham, we have our City Sandwell, we have our Royal Orthopedics, we have Children's Hospital, all the hospitals are around the table. Our community health care, we have primary care, then we have our community engagement partners. And some of these hospitals actually have their community engagement partners. They're also around the table. So every single person that is making decisions within Birmingham and Solihull, and our local councils, like I said, we have Solihull as well. I saw Neil Raj on the call as well. So every single person that needs to be is around the table trying to make sure that we hold ourselves accountable and we understand what needs to be done and commit to it. And most importantly is this co-production with our communities, hearing from our communities and making sure that their voices influence what we are doing. And I think that is what we had to do to be able to make sure that we build, and so that the communities can also see what we are doing and how committed we are to it.
Thank you, Oyin. Conscious of time, I've got another question about the volume of stakeholders and the number of players. As we know, we in Birmingham have about the population is about 1.1, isn't it, million or thereabout? And you've also got how many PCNs? You often have to remind me how many PCNs there are.
It's about 180 something.
And then you've got Solihull. But in all of this, you've highlighted that in West Birmingham alone, the Black African and Black Caribbean population is nearly 3 times as much as the other localities. So getting everybody to engage with this, but also then aligning all the different agenda into one vision. How have you managed that in terms of mobilizing and gaining buy-in for the BLACHIR opportunities for action?
I think for us, it was about the shared vision. Yeah, we all had to understand the importance of this. We've been given a once in a lifetime opportunity to actually, for once, engage with our African and Caribbean community. Not even just them now. Now we've also now had the Pakistani one launched recently, but it's to engage. We have that chance to engage with our communities. So it's about all of us having that shared vision to make sure that wherever or whoever we make sure that it's around that equality, that diversity, that inclusion, making sure that everybody feels included. But most importantly, like I was saying to you, at the BRIC conference last year, our chief executive, you can't get higher than that, committed the ICB to delivering this. There's a slide I sent that has to do with our reporting reporting framework. So within the ICS, you can see I have to report to our health inequality, our Health Inequalities board originally, but now they've changed it to People Power Health Inequalities Committee. That is where I have to go and report. Every quarter, I have to tell them what we are doing. And they directly report to the ICB board. So because of that, we have to then make sure, and they are supporting us to make sure that this work is being done. On the City Council side of it, we have to report to the BLACHIR Implementation Board, which at the moment has 2 ladies leading it, and they are really on the ball of what needs to be done and how this can be delivered. And they report to this Creating a City Without Health Inequalities Forum for every quarter, and they report to the Birmingham Health and Wellbeing Board that is chaired by Councillor Mariam Khan. And if you know Mariam, she wants to see this develop. She wants to see this working. She's really been a good support for us in terms of delivering this. In fact, she used to be the chair of the implementation board before we then got our bespoke implementation board chair. So she is committed. On the City Council side, there is that commitment. On the ICB side, the chief executive is committed to it. So that then gave us that, I wouldn't say authority, but almost like giving us that visibility to say this is a system commitment. It's not just about me, Dr. Okonkwo, or the task force saying we need to deliver this. It's about this is something the system has committed itself to delivering. And that has really, really been what has supported us and helped us to deliver the work.
Thank you very much, Onyinye. We've got 1 minute before we quickly have a look at the question for you to summarize all of this learning, because I'm aware that the work that's going on isn't just about equity in terms of access to healthcare, but also a need to ensure that the societal challenges we face can be addressed by creating healthier communities. You know, we talk about life expectancy, but more importantly, we talk about healthy life expectancy. We know that sadly, within our ethnic minority groups, people are more likely to be in ill health for at least 10 years or more within their lifetime compared to their non-ethnic minority or white counterparts. And it's important, especially for our working age group as well, that we continue to keep people healthy through the life when they are productive and able to give back to society, but more importantly, look after themselves and their families as we face the challenges of the economy and all that. Do you want to sort of summarize, you know, in terms of all that you're doing as an ICS and how you're taking all this learning and using it to shape the service planning, delivery, incorporating community voices, embedding all of this learning to make this more sustainable into the future?
I think for us, I think number one, because you did ask me about this when I talked about, okay, how are we going to, and you said, how are you going to drive this? I think the first thing for us is that stakeholder engagement. I can see here, Elizabeth is asking us about what do our community engagement look like? It's about the whole health system, as many as possible, you know, be it the ovarian cancer team, be it the perinatal mortality team, be it the vaccination, immunization and vaccination team, be the Dying with Dignity, the palliative care team, all of us actually going out as a group into the community and involving the community, giving them that access to come and talk to us. It's so important, because when you look at this model for improvement that I was talking about, you have to take a step back and ask yourself, what do you want to accomplish? How would you know that this change is going to make a difference? And what change can we make that will result? And if you follow this is exactly what we are doing at the base at the moment now, which is why we first started with, we've got the review. What does that mean to us? What are we doing at the moment? Why are these things happening? Yeah. And then if you're going to deliver any change, it has to be, that's why we have the community engagement partners literally marking our homework, sending us, you know, when I send it to them, I get it back and then I get the question mark. So what? What is this going to do? If I am the person here, how is it going to make a difference in my life? And that is where that creativity begins to come, because what we are thinking sometimes in the health system that is going to make a difference to our communities might not be what they need at that time. It's all about letting them and hearing from them and getting to those communities that feel they don't have a voice, allowing them to drive the work themselves, and then using that to bring into your system where you're constantly evaluating. So when we do all these community engagement events, they're evaluated, we hear what they've said, what they like, what they want to change, and then we're using that to kind of drive the next one. And before we actually even go out, we ask them, what do you want to see? What teams do you feel are relevant that you want to see for your event? And we build the community engagement program around you. So Elizabeth, as well, in answer to your question, we actually sample the community and ask them, like, it might well be that, okay, like the community, the diabetes event, we sent out a questionnaire to that community to say, what do you want to hear from us? And they told us about the immunization and vaccination, blood pressure, something about food, something about eyes, something about health watch, so that they know if they have questions, who do they have to go to, something about the what do you call it, the insulin pump and all this kind of, so they actually co-create with us what the day is going to look like. Like we have one coming up on the 4th of November at Legacy Center, and we've already started asking them, who do you want to see? They then tell us what they feel their community wants to hear at that point in time. And then we go back to the ICS and we start looking at who is delivering what. So if they say they want to see the cancer team, which cancer team? Is it the prostate cancer? Is it the ovarian cancer? Is it the lung cancer? And that is how we build the program with them. And then we all then turn up on the day. They have access to us. They can come and ask us questions. And also one of the other things that we tend to do is also have people from the ICS, because another thing is getting people into the ICS. If you're not around the table, you're on the menu. But if you're there helping the ICS to shape its thoughts and work in the ICS and, you know, contribute to what the ICS is doing, that means that you get that richer diversity within the ICS, and you can start from the beginning trying to co-create with each other. So that is how we are doing and how we're driving this work. And like I said, we're hoping that by the time we get to the 2 years that we're hoping that we will run this, we embed this as business as usual. That's what we're hoping to achieve.
Spot on, Onyinye. It's exactly 13:50 p.m. on the 12th of October. You've done brilliantly well, keeping to time, and more importantly, sharing your passion for this work with colleagues on the call. I can see the comments on the chats as well. People really acknowledging the amazing work you're doing. And I believe you've answered Elizabeth's question. Unless we have any other questions, I'll hand over to you, Eloise. Thank you so much to everybody who's joined us this afternoon.
Thank you so much, everyone, and thank you, Modupe and Onyinye, and thank you, everyone, for your comments in the chat. And I hope to see you at future webinars we've got throughout October. So thank you, everyone.
I think another thing I just say before you go, we still have some of our community, system partners. They're going to be running a few events. So if you want to hear more, say you want to hear, I think the next one is the children and young people group, where they're going to be discussing with some of our system partners. So if you want to hear more, please look at the calendar and join their session and hear a bit more in detail, because I've given like a strategic overview and they can tell you in detail what the kind of work that is being done. I can promise you there are really good, amazing work going around in the system, and they can tell you how they are doing it and all that.
Thank you so much.
Thank you.